So welcome everyone to the Canadian Public Health Association's Infectious Disease and Climate Change webinar series. This is the 6th webinar in our series, which is exploring current and emerging infectious disease and climate change topics to share knowledge, research, and best practices. Before we begin, I want to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin and Anishinaabe people. They've been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis people and their governments in realizing meaningful truth and reconciliation. Today's webinar, Emerging Vector-Borne Diseases in Eastern Ontario, Eco-Epidemiological Research in Action, is brought to you by the Canadian Public Health Association through the Infectious Disease and Climate Change Project. I'm Jillian Pritchard, Project Officer with CPHA, and I'll be the moderator for today's session. I want to take a quick minute to let you all know about some other infectious disease and climate change projects that we've undertaken at CPHA recently. You can find more information about all of them on our website at cpha.ca. Firstly, we recently launched a new resource package on our website, which is a compilation of the most recent research, knowledge and reports, tools, and other evidence-based information regarding infectious disease and climate change in Canada. Also, next Tuesday on October 5th, we'll be holding our first Infectious Disease and Climate Change Forum, which will provide a dynamic virtual environment to facilitate knowledge sharing of research and best practices among professionals and providers engaged in the field of infectious disease and climate change. We really encourage you all to attend this virtual event. And finally, we recently released a new report on infectious disease and climate change in Canada, which summarizes conversations with 16 key informants describing what is currently happening in the country with respect to climate change and infectious diseases. You'll find links to learn more about all three of these in the attendee follow-up email that I'll send later this week. We encourage you to check them all out. Just for a bit of housekeeping, it should be noted that all of our Zoom attendees are muted. And if you have any questions for the presenters, please type them in the Q&A box at the bottom of your screen at any point during the webinar. After the presentation, I will read out the questions and our presenters will answer them. If you have any questions regarding technical difficulties, please also put them in the Q&A box and we'll reply to you as soon as we can. And if multiple people are experiencing the same problem, we'll address it live. We really strongly encourage attendee participation and we really look forward to hearing all of your thoughts and questions. Just a few quick notes to let everyone know that this webinar is being recorded and will be made available on CPHA's YouTube channel a few days after the end of this presentation. And the presentation slides will also be shared in PDF in the attendee follow-up email. And we'd really love to get your feedback on this webinar, so please fill out our 5-minute survey, which will appear in your internet browser once the webinar is complete. Now I'd like to introduce our speakers for today's webinar. Dr. Manisha Kulkarni is an associate professor in the School of Epidemiology and Public Health at the University of Ottawa. As a medical entomologist and public health researcher, her research focuses on vector-borne diseases in tropical and temperate regions of the world. In particular, she's interested in understanding the impacts of environmental changes on vector-borne disease transmission and in evaluating and optimizing vector control interventions to improve the effectiveness of disease prevention efforts. Andrea Slatkulescu is a doctoral candidate in epidemiology at the University of Ottawa with a previous MSc degree in microbiology and immunology and a graduate diploma in population health risk assessment and management. Her doctoral thesis focuses on interdisciplinary methods to study the spatial and molecular epidemiology of Lyme disease and other tick-borne illness in Eastern Ontario. And Jay Logan is a doctoral candidate in epidemiology at the University of Ottawa with a master's degree in geographic information science. His doctoral thesis examines social and environmental effects on Lyme disease risk with a focus on the impacts of urban landscape change at the city scale. With that, I'd like to turn it over to our presenters.
Thanks very much, Jillian, for those introductions.
Thank you.
So our talk today will be examining some of the research that we have been doing in my lab at the University of Ottawa. At the Insight Research Lab, the Interdisciplinary Spatial Informatics for Global Health Lab, we are exploring socio-ecological determinants and drivers of vector-borne disease emergence and risk in global settings, with projects in East and West Africa and Latin America. But here in Canada, we also have a number of projects that are focusing on mosquito-borne viruses and tick-borne diseases, including West Nile virus and Lyme disease. And we're applying multidisciplinary methods using field-based, laboratory-based, and spatial analytic approaches. In addition to the projects that we lead here at Insight, we collaborate with partners across Canada and the Canadian Lyme Disease Research Network and ETIC. And we have funding from the Public Health Agency of Canada's Infectious Disease and Climate Change Fund, as well as CIHR and NSERC. So what is the context of emerging vector-borne diseases? Well, based on some of the earlier work and reviews that my team has conducted, the common feature across many vector-borne diseases globally is the ongoing climate and environmental changes that are impacting vectors and disease transmission. We know that globally there's an expanding risk of dengue, resurgence of malaria in many highland areas. But here in Canada, we're also seeing emerging vector-borne diseases such as increasing Lyme disease incidence, where we live here in Eastern Ontario, which is also occurring elsewhere in Canada, as well as the ongoing risk of climate-driven epidemics of West Nile virus. So global changes are driving a lot of vector-borne disease emergence events, and these global changes encompass changes in a wide range of global scale phenomenon. So we're talking about population growth and demographics, the economy and resource use, land use and land cover, urbanization, climate change, and other environmental changes are very important and are all interacting in a very complex, dynamic way. So looking at some of the vector-borne diseases that we find here in Canada, West Nile virus is a mosquito-borne virus that's transmitted by different mosquito species with bird amplifier hosts with an enzootic transmission cycle and spill over to other dead-end hosts such as humans. Lyme disease is another vector-borne disease transmitted by ticks. Here you can see the life cycle and the progression from different stages from larva to nymph to adult that feed on different hosts. And here the nymphal and adult ticks are the most important for transmission of diseases to humans who are also dead-end hosts. So when we're looking to define what is vector-borne disease risk, we need to consider elements of the hazard, which is really defined by the entomological risk. So the density of mosquitoes or ticks in the environment, the proportion of them that are infected with the pathogen, and how many of them are biting humans. But we also really need to consider the social aspects in terms of vulnerability. And this relates to factors that are associated with human exposure to vectors, as well as their susceptibility. So in defining risk using both hazard and vulnerability, we're examining socio-ecological determinants. And I'll mention that the talk today will focus mostly on our Lyme disease research that we've been doing here in Eastern Ontario. So how can we characterize disease risk to better target interventions? Well, we can use a variety of different data sources. Vector surveillance data, we can use reportable disease surveillance data, as well as other types of spatial data that can be integrated using methods such as spatial analysis and statistical modeling and risk mapping. And our overall goal really is to understand disease ecology and epidemiology and identify disease transmission hotspots. And this in turn can help us inform vector-borne disease prevention and control. So looking a bit closer now at Lyme disease and some of our research, as many of you are likely aware, Lyme disease is a tick-borne bacterial disease with rodent intermediate hosts. The agent of Lyme disease in North America is Borrelia burgdorferi sensu stricto, it's spirochete. The vector in eastern parts of North America is Ixodes scapularis, the black-legged tick. You can see the photos of different stages of ticks here at the bottom, those that are haven't fed yet and those that are engorged with blood. And you can see their size, very small, which relates to their ability to go undetected after they've bitten a human host. The reservoir is white-footed mice, Paramyscus leucopus, among other types of small mammals and birds. These black-legged tick vectors have a 2-year life cycle with 4 different life stages. And it's really the nymphal stage that is related to the highest risk of human infection. This is because they become infected by acquiring infected blood meal as a larva. When they're seeking their next blood meal on a host, they can bite humans as well as other types of different hosts. They're active in the late spring and summer when people are active in the environment, and they're very small relative to the adult ticks. So you can see the second one in here is a nymphal tick about the size of a poppy seed. So very difficult after it has attached to a person to actually see it and remove it. Lyme disease signs and symptoms and disease progression can range from an early localized acute disease to disseminated and late disease if untreated. The early localized disease occurs within days to weeks of infection. One of the typical signs is an erythema migrans rash, characterized by this bullseye rash that you see, but it only occurs in about 70% of cases and may go unnoticed. It's usually accompanied with a flu-like illness, which again could overlap with symptoms of other diseases. If untreated, the disease can progress to disseminated disease and can have arthritis and cardiac and neurological implications, with late disease leading to large joint arthritis and other manifestations. So very important to recognize and treat early. Lyme disease is emerging in Canada to a variety of different due to a variety of different factors. So of course, climate change is causing warming temperatures, and this is permitting the expansion of tick vector geographic range into parts of Canada. The map on the right shows the distribution of black-legged ticks to the south of us in the United States. You can see many of these areas are bordering southern parts of Canada, where warming temperatures, of course, are permitting the northward expansion of these vector ticks. This is being driven in a substantial way by the northward transport of ticks by migratory birds from these endemic regions in the United States and from established tick populations in southern parts of Canada. Also by the expanding range of the host populations, so the white-footed mice and white-tailed deer. And in conjunction with climate change, we're seeing habitat fragmentation and biodiversity loss, which all interact in complex ways to drive disease emergence. So it's really important to identify these Lyme disease risk areas. This is because to acquire Lyme disease, a person has to be bitten by an infected tick, and the risk is greatest in areas where tick populations are established, and risk depends on the proportion of ticks that are infected. So by identifying risk areas, we can identify where people are most likely to be infected. Also, information on the location of risk areas is helpful to target and motivate preventive efforts, but also to properly interpret clinical and laboratory findings as part of the Lyme disease case definition. Expansion of Ixodes scapularis, black-legged ticks, is driving an increase in Lyme disease incidence in Eastern Ontario, and this is what we'll be showing in some of our research, putting new areas and populations increasingly at risk. But we're also concerned about other emerging tick-borne diseases. The same tick vector can transmit babesiosis, anaplasmosis, other Borrelia species, as well as Powassan virus. And you can see that many of these have been recorded in the northeastern and midwestern United States, and again are moving northward with the expansion of tick populations in parts of Canada. Previous field surveillance activities for black-legged ticks through active and passive tick surveillance have identified many regions with ticks that have been found in the environment, including in parts of Ontario and Quebec, in the Maritime provinces, and in southern Manitoba. In Ontario specifically, Lyme disease risk is identified through mapping of risk areas. So this is by identifying ticks that are found through active surveillance in the environment over 2 consecutive years. And with a 20-kilometer buffer around these areas, risk can also occur, or I should say ticks can also be encountered in other parts, of course, of the province where they are transported by migratory birds. So these adventitious ticks can be found in many areas. However, the highest risk is in areas with suitable tick habitat, so wooded areas, and areas with established tick populations. These maps, the map and the graph here show some of the recent data on Lyme disease in Ontario between 2012, 2017. We can see increasing incidence of Lyme disease in the province. We've seen similar high rates in recent years, and the trend's likely to increase in coming years. The incidence of Lyme disease is concentrated in various parts of the province in southern eastern Ontario, mostly in those areas that are closer to the United States and the St. Lawrence Seaway. And this is the region where we have been conducting our research. So I mentioned there's different types of Lyme disease surveillance in the province. There's notifiable disease surveillance where healthcare providers diagnose and report cases to public health. We also have passive tick surveillance where ticks are submitted by the public or healthcare providers for identification and testing. This has been transitioning now more to image-based identification through online platforms such as eTick. And these types of surveillance activities provide early warning signals for ticks and pathogen emergence in new areas. When we have a signal from human cases or from passive tick surveillance, we can then go into the environment and sample for ticks, collect them via drag sampling. Here you can see the method dragging a flannel over the surface of the vegetation to pick up ticks that attach, or from small mammal hosts. And risk areas can be declared if ticks are found in 2 consecutive years. And established sites are identified if all 3 tick stages are found in 2 consecutive years. So one of our preliminary studies to look at what was happening in Eastern Ontario with Lyme disease used these different types of surveillance data to look at the trends over time and space in these 3 health units of interest in Eastern Ontario. So the Kingston, Frontenac, Lennox and Addington Health Unit with the City of Kingston, in the southern portion, Leeds, Grenville, Lanark, and the City of Ottawa Health Unit. You can see the major boundaries of the health units here in the dark black, and in the light gray are the forward sortation area boundaries. So this is the first 3 digits of the postal code. So one of the first things we did after looking at some descriptive trends in terms of age distribution and patterns in terms of difference between male and female was to map the Lyme disease incidence by this forward sortation area unit over time. So these maps show from 2010 in the top left, 2016 in the bottom, with the darker colors reflecting higher Lyme disease incidence per of cases per 100,000 population in that forward sortation area. So what we noted was that in 2010, the cases were largely restricted to areas along the St. Lawrence River in the southern portion of the study area. However, over time, we did see a rapid northward spread of Lyme disease incidence since around 2013, reaching further into the Ottawa area during this time period. This mirrored some of the changes that we saw in the prevalence of Borrelia burgdorferi in black-legged ticks that were submitted from passive surveillance. So this is from the passive surveillance data that we received from the province. And again, the maps from 2010 in the top left to 2016 in the bottom, showing darker colors reflecting higher percentage of black-legged ticks that were infected. We saw that there was significant change over time in the location of ticks that were submitted from residents of these areas that were infected with Borrelia burgdorferi, with general increases over time in the prevalence of Borrelia burgdorferi. And when we looked at associations in statistical models between the time to the first human case and the time to the first reported infected tick from these locations, we identified that there was about a 1 to 2 year lag between the first infected tick and the first human case, controlling for distance to the first human case reported, as well as population. So there really is a good link between tick surveillance and human disease surveillance. Looking a bit more closely at this with different types of spatial analyses. On the left, spatiotemporal cluster analysis using Koldorf's spatial scan statistic identified a significant cluster of Borrelia burgdorferi infected ticks, shown in the blue circle here, and that was between 2012 to 14. And this overlapped spatially with clusters of human Lyme disease cases. And what's interesting to note is that, again, the clusters of infected ticks preceded the clusters of human cases by about 1 to 2 years. The figure on the right shows the directional distribution of these Lyme disease cases, showing where the concentration of Lyme disease incidence is found in the different years, with the black circle in 2010, expanding up to the red circle in 2016. And analyses are underway, which you'll be hearing about from my colleagues shortly, to investigate socioecological determinants. So I'll pass it over to Andrea to talk a bit about her research on Lyme disease risk factors.
Thank you. Okay, so as Dr. Kulkarni mentioned earlier, there are various factors that affect Lyme disease risk overall. And so traditionally, environmental risk encompasses tick ecology, which looks at factors associated with tick lifestyle, distribution and spread, as well as habitat colonization, as well as pathogen dynamics that look at the pathogen's transmission cycles in any animal reservoirs. The societal risk for Lyme disease generally looks at human exposure to ticks, and this focuses on risk behaviors as well as knowledge, attitudes, and practices that an individual might have towards vector-borne diseases. And so for my thesis, and some of the work I will be presenting today, I'm really aiming to look at the epidemiology of Lyme disease from these multiple perspectives. Next slide. So again, we've seen this map previously, and as Dr. Kulkarni mentioned, it is based on active tick surveillance across the province. Generally, this creates a 20-kilometer buffer radius around 2 years sites where we found more than one tick. Now, this kind of Lyme disease risk mapping has several limitations, and the first is a broad scale. The site selection is also based on passive tick surveillance as an early indicator of where ticks might be found. It also shows the probability of encountering ticks as being fairly uniform across the region. And it also doesn't provide any kind of projections outside of these sampled areas. Next slide. And so for my first study objective, I wanted to develop predictive species distribution models for Ixodes scapularis and Borrelia burgdorferi, looking at biotic and abiotic factors that might affect habitat suitability using maximum entropy modeling. For those who might not be familiar, maximum entropy modeling, or MaxEnt, is a machine learning algorithm that contrasts the presence locations of ticks with randomly selected background locations while accounting for a whole slew of environmental variables that might affect the tick's habitat. This then generates a probability map that can be interpreted as habitat suitability from 0 being low to 1 being high. Next slide, please. So for my first the study objective, we used field collected ticks from 120 sites that we sampled across southeastern Ontario from 2015 to 2017, and various satellite remote sensing data looking at variables related to land cover and land use, as well as climate averages to look at temperature, precipitation, and also elevation variables. Next slide, please. So this is the model that we generated for Ixodes scapularis, and this map shows habitat suitability from, again, low being 0 in blue and 1 high in red. This map is at 100 meters resolution, and we can see that the concentrated habitat suitability for Ixodes scapularis ticks is predominantly between Kingston and Ottawa, as well as other hotspots around the shoreline of Lake Ontario, with a little bit more diffused risk across the rest of the province. We found that temperature, especially degree days above 0 degrees Celsius, increased habitat suitability for ticks, whereas elevation and distance to both types of coniferous and deciduous forest decreased habitat suitability. We also generated a similar map for Borrelia burgdorferi, but for brevity, it's not shown here today, but you can find it at our published paper. Next slide, please. So what we found is that these two high-resolution species distribution models showed actually really good predictive accuracy when we tested it against multiple independent data sets, including active tick surveillance from the following year, as well as publicly submitted ticks during the same time. These models indicate heterogeneity in risk across southeastern Ontario, and we're also able to detect some regions of growing environmental risk that wasn't shown before, especially around Algonquin Park and around the Georgian Bay. And we hope that these kinds of maps can be used to identify new sites for tick surveillance and inform future research on environmental risk factors for Lyme disease. Next slide, please. So as we mentioned before, there are various factors that affect Lyme disease beyond just the environmental risk measures. And in Canada, in particular in Ontario, there's very little information about other types of Lyme disease risk factors. So for my second objective, I really wanted to fill some of these knowledge gaps and identify some socioecological factors that contribute to Lyme disease. Next slide. This study is concentrated in Eastern Ontario for 4 public health units, and we're using data from 2010 to 2017. Here I'm using Lyme disease patient data from the Integrated Public Health Information System, which contains reportable disease surveillance data for Ontario, as well as passive tick surveillance data from Public Health Ontario. Next slide. So we generated a negative binomial multivariate regression model to identify socioecological risk factors at the dissemination area. And this is the smallest area that we had census variables available for. We found that in Eastern Ontario, the Lyme disease incidence was actually associated with lower urbanity, with presence of ticks in the environment and lower population density, as well as higher socioeconomic status of individuals that might increase the exposure to these tick areas. This will help devise appropriate risk mitigation strategies and tailor the public health messaging to these higher risk regions. And it also highlights the importance of fine-scale studies to further identify neighborhood level patterns and other determinants of Lyme disease. And I will now turn it over to Jay, who will look a little bit more into the details at the neighborhood level.
Thank you, Andrea. As Andrea said, I'm going to take you from a little bit of a wider scale view down to the local level. And I'd like to first highlight the fact that especially in endemic areas of Borrelia burgdorferi and Lyme disease, there's increasing attention that is paid to residential and peri-domestic or suburban exposures that result in Lyme. And that in these studies, the level of aggregation that the researchers are looking at still looks at a unit of study that is very large in most cases, where we're looking at the region or the county level. 2 years ago, there was a systematic review done across multiple levels of residential cases. And while this article you'll see at the bottom here mentions yards, neighborhoods, and beyond, it's really the and beyond that is sticking out through a lot of the research papers being done to this point. So I'm hoping to contribute a little bit more to the neighborhood level, looking what changes at the local unit might affect. Next slide, next slide, please. So when we're looking at risk factors at the local level, I'd like to emphasize that the scale that we're looking at has an effect on both halves of the risk equation that Dr. Kulkarni indicated before, where when we're looking at environmental measures and the hazard element, those studies have primarily focused on wider regions or more broadly across communities in Canada, and even in long endemic areas, particularly the Northeast United States. Attention is paid a lot on the vulnerability side, mostly focusing on individual behaviors, and even the area-based risk factors like socioeconomic and physical are, again, as we'll see on the next slide, examined rarely lower than the county or community, state, or even regional level. Next slide, please. So here, in the center of the slide, you'll see a study by Tran and Waller, where they looked at the variability of incidence determined by ecological factors that was you could parse out by different levels of region. So they looked across the entire eastern seaboard of northeast seaboard of the United States and broke that into 2 smaller regions. So the difference in looking at regional variability. Brownstein looked at the proportion of, excuse me, the patch size and patch isolation of forested land at the town level and what that meant for tick density, infection of Borrelia burgdorferi amongst tick populations and human incidence at the, in those towns. Dirk Wasser and researchers also looked at the proportion of the population living in low intensity developed areas. So kind of that interface between wild and urban land and what that meant for county level incidence. So again, aggregating across a larger part of the region and what the amount of forested land versus what that has been developed into residential or industrial land does to the incidence that can be expected. And more in line with what I'm going to be explaining a bit further in a moment is this research done by Socioecological in 2015, where that team looked at the proportions of land cover, so forest or herbaceous or developed land, and demographics, and what that meant for incidence at the census tract level. And while the census tract is a good smaller unit of analysis, it's primarily driven by finding or equitable distribution of population numbers, but doesn't really tell you a lot about the communities or the neighborhoods and about the population that lives within those tracts. Next slide, please. So the objectives of the research I'll be explaining are that I wanted to look at the socioeconomic, demographic, and physical area characteristics of neighborhoods that are associated with specifically residential Lyme disease risk. And as part of that physical area component, demonstrate the use of temporal and spatial high-resolution imagery to evaluate the local environmental risk. So again, where Andrea is looking at the use of satellite imagery to define the hazard across broader regions, I'm going to see if we can piece that a little lower and look at if we can say anything about the local risk for residential cases through higher resolution imagery. And to do that, I took satellite imagery and used a machine learning algorithm known as random forest supervised classification that allows us to take training data that tells the algorithm what types of pixels in the image are different classifications, in this case, forest or low vegetation, herbaceous, developed land or water, and identify which pixels can be assigned to those different classes. And then using all of those different variables, hopefully develop a model to identify the expected number of cases or the incidence that is given by neighborhood composition, by those socioeconomic and physical environments. Next slide, please. The data sets I was using for these analyses. For the outcome, again, using the Integrated Public Health Information System, Lyme disease patient data, where the age, sex, episode date, home address, and travel history and exposure information are available. Focused on cases from 2017 to 2020, specifically where the exposure location listed as the first or most likely exposure location was the home address, or could be identified as basically the home or the residential location of the patient. Next slide. And where I aggregated these data down to is the neighborhood boundary defined by the Ottawa Neighbourhood study. And one of the reasons this, I wanted to use this boundary level as opposed to something like census tract is that while the population is fairly kept smaller for this level of area, the boundaries that are captured by the Ottawa Neighbourhood study reflect the physical and social similarities that affect area residents, and can offer a local level of aggregation where the changes that we might detect within these boundaries may impact these aspects of the community more, or we might be able to detect more at this level. So some of the data or the variables that we selected from the themes offered by the Ottawa Neighbourhood study are standard of living, so household tenure, ownership, or rentership, low income prevalence, specifically low income prevalence among children, or low income prevalence in homes of children, the median household income and proportion of the population in certain occupations, specifically agricultural or resource extraction, and construction or utilities, aspects of the community, so walkability within the neighborhood, population demographics by age and immigration statuses, the education level of the population, and as well as metrics of environment and sustainability, so the amount or per capita aspects of walking, cycling, and trail networks, and the recreation resources available in the communities. Next slide. And to add to the physical area aspects, the satellite imagery I was using is images from Planet Labs offered through their education and resource program. And Planet Labs offers from their PlanetScope satellite network that takes images around the world daily for everywhere on the globe, 3-meter resolution at several times a day, which allows the opportunity to stitch together a mosaic that eliminates cloud cover, allows us to classify every 3-meter piece of the terrain across the city of Ottawa, and hopefully for future research, look at the any changes we might detect at a much more local level. So as we progress into the next slide, you'll see some of the effect of using that random forest classifier, where one of the things we're most interested in here is looking at the forested cover of the lands, and the red boundaries you see on the map are some of the neighborhoods superimposed on what is now the classified image. Next slide. So, and from the classified image, I derived a number of measurements of the neighborhood forest cover and fragmentation that capture some of the similarities to the research I highlighted earlier, where we're looking at the proportion of the neighborhood that is forested, the number of forest patches in a neighborhood, as well as the amount of forest edge that is measured across areas, so the forest edge density. And the last measurement I looked at was the distance between every municipal address in a neighborhood and the forest edge in meters. And this is an important one because at that in that systematic review that I indicated in the first slide, one of the neighborhood level dominant variables that arose was the incidence that could be told by the presence of woods adjacent to or within 500 meters of a yard. So hopefully by this, we can kind of get at landscape design guidelines that might come from how close to a forest edge an individual property might be. Next slide. So in this analysis, I used multiple variable regression modeling using a negative binomial model adjusted for 2016 neighborhood population from the 2016 Statistics Canada Census, looking at the neighborhood as the unit of analysis with an outcome of residents exposed Lyme disease incidence, and using the predictors of median household income after tax, prevalence of children living in a low income household, number of forest patches, average distance to forest edge density, proportion of forested area, and proportion who did not complete high school, population aged 0 to 14, and 65 and older, to align with some of the known demographic risk factors for Lyme. Next slide. And while some of these results aren't published yet, I'd like to highlight some of the significant things about the results we have found. Primarily that Lyme disease risk is impacted by changes to the fragmentation of forested land in neighborhood structure. true particularly of wealthier peri-urban neighborhoods, where the neighborhood is primarily single-family homes that border woodlands. And in this, we see that as we increase forest edge density, we see a decrease in incidence. And as we increase the number of forest patches, we increase the cases. So as you change the dynamic of how that landscape structure is formed, there's a trade-off between what level of impact you have on Lyme disease risk to that neighborhood. Second, that hopefully as we develop these, it can inform guidelines for neighborhood and community development that minimize the introduction of risk where growth and adaptation are planned for a neighborhood. And finally, that it's important to consider the individual and local hazards, the neighborhood hazard, as much as the behaviors, those knowledge, attitudes, and practices that the individual exhibits when we're talking about the vulnerability piece. Thanks, and I would like to pass it back to Manisha.
Thanks very much, Jay. So you've had a bit of a sneak peek at some of the research that's been going on in the Insight Lab. I just wanted to highlight quickly before we go a few other projects that we've been working on. The first is the Ottawa Tick Study. So this was funded by the Public Health Agency of Canada, wrapped up in 2020. And the project was called Improved Early Warning for Climate Change-Driven Emergence of Lyme and Other Tick-Borne Diseases in Eastern Ontario. In this project, we sampled a number of sites, about 28 sites across Ottawa, every spring and fall from 2017 to 2020, doing active tick surveillance to look at changes in risk over time. And this was recently published in PLOS One. To do the active tick surveillance in Ottawa, we go out and do drag sampling to collect ticks from the field, bring them back to our lab where we do species identification. The black-legged ticks are then processed for nucleic acid extraction and detection of genetic markers of various pathogens using quantitative PCR, using different markers, as you can see here in the algorithm, which shows testing for Borrelia and confirmation for different Borrelia species and anaplasma. So in terms of some of the results we saw over the 3 years, here we see the sites mapped according to the density of black-legged ticks. This is the number of ticks per person hour of sampling in the gray circles, and the density of infected ticks in the red circles. So what this map shows is that the highest tick density sites and those with the highest tick infection rates were located in areas within the Greenbelt zone and in suburban and rural areas in the western portion of the city. This lines up well with what Jay has shown in terms of some of the Lyme disease incidence data, while the lowest tick densities occurred at sites in the suburban and urban core. And again, this lines up well with what we know about habitat suitability in the region. Several sites with Borrelia burgdorferi prevalence in ticks above greater than 30% were identified. And what we wanted to do then is to look at, over time, how did the tick density and infection rates change according to the criteria of tick establishment that have been identified by Chloe et al. In their research looking at a field indicator for classifying tick establishment. So we looked at multiple cohorts of ticks in the spring and fall and classified sites as high stable, emerging, low stable, or non-zero, according to the observed changes. We identified multiple high stable locations, and these are areas where tick populations and Borrelia burgdorferi infection was present over multiple tick cohorts. So we can say with some confidence that in these regions, we do have established tick populations that do present a risk to human population exposure. Another project that we're working on actively at the moment is funded by the Public Health Agency of Canada Infectious Disease and Climate Change Fund. It launched in 2019, just before the pandemic kicked off. And so we've been conducting field research for the last 2 summers in selected neighborhoods in Ottawa to really get at some of these aspects that Jay was talking about in terms of landscape composition and hazard and exposure. So characterizing landscape characteristics, conducting tick surveillance and wildlife host sampling to really understand some of the ecological drivers of hazard of infected ticks in the environment. We've had one virtual town hall so far that's published on our UpTick website, and try to do a lot of other outreach activities in the neighborhoods to increase awareness of Lyme disease. A newer study that we have is collaborating with the National Capital Commission, and they're supporting us starting this year for 3 years. And this is the Greenbelt Tick Study. It builds on some of our earlier work where we're looking to develop sustainable environmental control measures to reduce the exposure of people to ticks on recreational trails in Ottawa. So again, we've done a fair amount of public outreach together with the NCC to alert the public to the nature of Lyme disease ecology and risk in endemic settings. And we've done an intervention study looking at the application of wood chip borders along recreational trails, which we found significantly reduced the density of questing ticks in the region. And we are continuing the study over the next 2 years, looking at other types of integrated control measures. So to sum up, vector-borne diseases are emerging worldwide due to ongoing global changes. And of course, Canada is not an exception, with tick and mosquito-borne diseases expanding northwards. As we saw today, the expansion of black-legged ticks in Eastern Ontario poses increased risk to the public health due to Lyme and other tick-borne diseases. And importantly, we can use eco-epidemiological research to identify these transmission foci that could be called risk areas for humans, to help us understand social and ecological determinants of disease risk, and to inform targeted disease surveillance and control. So I'd like to thank you all and acknowledge the members of our Insight Lab at University of Ottawa, as well as our collaborators at Ottawa Public Health, the National Capital Commission, Public Health Agency of Canada, and the Canadian Lyme Disease Research Network. And thank you very much. We'd be happy to take questions.
That's great. Thank you so much. That was a very interesting presentation. Thank you to the three of you for sharing the work that you've been doing. Looks like you've been very busy. I'd like to take this time now to remind everyone to please submit your questions into the Q&A box that you'll see at the bottom of the screen and put them in there, and then we'll read them out to our presenters. We've got a few that have come in already, so we'll start off saying, so interesting. Can you comment on the implications of the neighborhood level research in local government community planning, i.e. built environments? And they stated that tree canopy in urban environments is beneficial for so many reasons. Thank you.
I'll give a quick answer, then I'll pass it over to Jay to follow up, perhaps. In terms of neighborhood level research, what we're really hoping to do, and by engaging with the City of Ottawa Planning Department, we know that when we're looking at climate change adaptation strategies and especially focus on green infrastructure, we really want to be able to identify, how some of the greening initiatives, while they have so many benefits, may be able to be optimized to ensure that we're mitigating risk for things like vector-borne diseases. So in terms of incorporating research into local government, I think it's really important for us to have opportunities like this to engage and translate knowledge broadly, but also to engage directly with stakeholders to share our results of our research. And this is one of the key goals of our UpTick research project, is to use the information that we're gaining from the study neighborhoods to develop a framework for risk estimation and to integrate that into other frameworks for healthy urban planning, for example. So those are some of the future objectives we have for the project in the coming years. And Jay, do you have any other thoughts on that?
You covered it pretty well. I think I might just say that I agree that the tree canopy in urban environments is very beneficial. And one of the reasons we're trying to explore this is to be able to offer the maybe numbers that can back up how you can strike a balance in growth that is going to be inevitable, as well as allow for the opportunity for climate change adaptation to create greenery and not allow increased risk in those communities.
Yeah.
Great, thank you. We've got another question here saying that you mentioned eTick for identification of ticks. Can you describe how it is used and accuracy? And I'll just throw in a note here that if you go back into the CPHA's YouTube archives, we did have Jade Savage from the eTick project who did a whole webinar on this. So if anyone's interested in learning more, please do go back and learn that. But perhaps you could comment on maybe if there's an interaction between your two projects or how you use that information.
Yeah, no, it's a great question. eTick is becoming increasingly important as an early indicator of expansion of tick populations. Both Jay and Andrea serve as regional experts for eTick, for the tick identification, so they can tell you in great detail how they go about it. But essentially, we receive through the eTick platform images that are submitted by users. So people can either register on the site as a user or submit as a guest to a photo of a tick that they've found on themselves or on their pet. If it's on a person, it comes to our group at the University of Ottawa. The image is identified to the species level to the best of our regional experts' efforts, depending on the quality of the image and the type of tick that's present. And an automated message is sent back to the user telling about the identification of the tick and any implications for diseases that may be transmitted by those certain types of ticks. And a point location is then put on the map for where those ticks were encountered. So in terms of accuracy, we're only able to, well, maybe I'll let Andrea comment on how the ticks are vetted and the proportion of them that are actually able to be identified.
Yeah, so as Manisha was saying, we mostly receive images from the public, and for those we have to identify the species. And then we also look to see if the region makes sense. We kind of just zoom in on the map to make sure, but it's not in too much detail, and we rely really on it being self-reported by the user. Now, if something is a little bit out of the ordinary, or maybe there's some sort of travel related, I know we've had some submissions where people were maybe also traveling, but also local risk. So then we have to take extra care to look at those submissions. And sometimes we request them in the lab just to make sure and confirm our identifications and observations. But it's mostly user-based in terms of the location.
Thanks, Andrea.
Great. Thank you. I've got another question saying, great talk, thank you. Have you noted any increases in anaplasma in your tick samples over the past few years? And if yes, has the distribution differed from Borrelia?
So yes, we have noted some anaplasma in the ticks that we've been collecting in our active surveillance activities. It's a very low prevalence in many sites, 1 or 2 individual ticks. We've noted them in a couple of the sites, again, where we have very high tick densities and high infection prevalence of Borrelia. So those are some of the western areas of Ottawa. But it does seem to be showing up in more sites in recent years. So it's something that we definitely have on our radar. And I should mention that we are collaborating with our local public health authorities and with provincial public health to ensure that they have this type of data to inform their decision-making as well.
Great. Thank you, that's interesting. I'd just like to take a moment to encourage anyone who has questions to please put them in the Q&A box and we'll read them out because we still have a few more questions, a few more minutes. In the meantime, I'd love to ask a question. Do you have any advice for researchers who may be in other regions who are looking to do surveillance on ticks in their region?
Well, I think it's just a matter of having the time and the resources to get out to the field. I think it's a really good idea to speak with your local public health unit and public health authorities to see where the sites are that would be most beneficial to sample. Also getting in touch with the Canadian Lyme Disease Research Network. We have a pan-Canadian sentinel surveillance network that's been set up with sentinel regions in every province that we're contributing to tick surveillance every year to track the risk over time. So there are many opportunities to go out and collect data. The challenge is then getting the laboratory resources to test the ticks, and ensuring that the sampling methodologies that are followed are standardized so that we really do have comparable data across different regions. So that's one aspect that we've worked hard to coordinate with partners in terms of standardized methodologies. And then it's just a matter of timing. So if you're looking to collect the adult ticks, generally the spring and the fall are the seasons where they're most active, and the nymphal ticks are most active in the late spring and summertime.
Great. Two questions for Jay. So how sure are you that the exposure is from their home and not from traveling or somewhere else? And since high socioeconomic in general equals single house closer to parks or forest, how do you take that into account into regression, i.e. what is the correlation between those two variables?
Unmute thyself. So first question, how sure are you that the exposure is from home? There is the likelihood that some of the outcomes may be misclassified just based on user error or self-recall bias of the individual patient. I will say that in the public health data, patients are allowed to offer up to 5 potential exposure locations, and the great majority of those only offer 1, maybe 2 locations, and the number of the proportion of those that name the residence is only about 20%, and those that name their home as a second or further down the list location is very low. So fairly certain if the patient is very certain, but beyond that, I can't offer anything as to how accurate the exposure might be. We're playing on patients' recall and their expectation that it came from their property. And then your second question, high socioeconomic equals single house closer to parks forest. So the regressions are using the variables for socioeconomic status in different models, a socioeconomic variable alongside forest composition variables. So the one that I mentioned had a low income, children living in low income households prevalence with some of these, the forest cover, and controlling for one, we're seeing the effect of the other. So the fact that we're controlling for one of them and seeing an effect in some of the other variables is what is coming out. Now, the correlation between those two, I did look at which variables before going into the regressions had high correlations among the variable at the neighborhood level, and tried to omit those before performing the regression. So try to prevent the high correlation from having an impact on the regressions themselves. I hope that answers your question.
Thank you. I've got a question here asking, how long does a tick need to attach in order to transmit disease?
I'll take the question. So it's not an aspect we're looking at directly in our research. We don't have the lab capacity to do infection studies, but based on the literature, it differs for different pathogens. So for Borrelia burgdorferi, it's thought that it takes at least 24 hours for the bacterium to transmit from the midgut up into the salivary glands and be transferred to the host, whereas for other pathogens like anaplasma and powassan, they can be transmitted much more immediately. So that's why for Lyme disease, at least, it's really important to do a thorough tick check and remove an attached tick as quickly as possible, because the probability of transmission of infection does increase with the duration of tick attachment. Yeah.
That's great. Thank you. Well, I think we've come to the the end of our questions and the end of our time here today. So I'd like to thank the three of you for presenting your work today. It's very interesting, and I think all of our participants got a lot out of our discussions. Just a quick reminder to all our attendees to please fill out a survey that will open in your web browser once you close the Zoom application. It's really helpful for us to hear your feedback. And thank you all for joining us, and have a wonderful afternoon.
Great. Thanks, Jillian.
Bye-bye.